And Ethan is you want to just reintroduce yourself?
Yeah, hi everyone. So I'm a medical graduate from Taiwan, for those who don't know me, and hope everyone will enjoy the case today. Yeah.
Wonderful. Thank you so much, Ethan. Whenever you're ready, go ahead and get started.
Yeah, so today I have five aliquots, and in the fifth aliquot, I'll reveal the final diagnosis. So I'll start with the chief complaint. Today we have a 72-year-old lady presenting with progressive jaundice for 3 weeks. And she was diagnosed with gastrointestinal stromal tumor 3 months ago and underwent a laparoscopic partial gastrectomy 2 months ago at another hospital. And after the surgery, the patient had an uneventful recovery. And 1 month ago, she started to develop jaundice and tea-colored urine. And the lab in the clinic showed elevated liver biochemistry with AST of 116 and ALT of 128. And she also had hyperbilirubinemia with a total bilirubin of 3. And in review of system, she also had poor appetite. And she was negative for fever, nausea, vomiting, diarrhea, abdominal pain, and bloody stool. And that's the first aliquot.
All right. So we're starting off in the problem space of jaundice here. And I think just sort of our general approach to understanding how to think through somebody who's presenting with new jaundice, right? We can sort of break it down by the two different primary pathways by which someone can develop hyperbilirubinemia or jaundice. And the most common pathway is going to be via hepatobiliary disease. And then a less common, but certainly relevant pathway is oftentimes going to be through things that cause an indirect hyperbilirubinemia, particularly things like hemolysis. And there's many ways that we can try to parse through the probabilities of whether it's a hepatobiliary cause or a hemolytic cause. But I think the easiest one is to just look where the action is. And in this case, we already have lots of action below the diaphragm in the intra-abdominal space. We have a known stromal tumor, we have prior intra-abdominal cancer, and we have sort of early satiety and anorexia, all of which I think push us into thinking about a hepatobiliary cause of jaundice. And I'll just pause there, just as sort of a basic overview and kick it over to Sharmin.
Yeah, I love that. And yeah, and I think like when a patient like this comes to us, the question is like, is this a new process or is this a complication of a prior process? So I think those are the two things that we have to contend with as we're going forward. So just kind of thinking about like the GIST tumor themselves, it's a very rare tumor. Often, and when I think about then the cancer, it's like, oh, are we dealing, if this is related, is it related to a spread of a cancer? Are we dealing now with a metastatic disease that has gone to the hepatobiliary syndrome? I don't have like hemolysis in my illness script as like a complications of a GIST tumor. Oftentimes I think the perineoplastic is like hypoglycemia of some sort. Or is this also a complication of a potential surgery that she's had that has caused some damage to the hepatobiliary? So I think those are thinking about like whether the cancer has metastasized, is there any other like perineoplastic complications of the cancer, or the procedure itself that can have led to some sort of complications, or are we dealing with none of the above? As Jack mentioned, then thinking about our the beauty of a framework is that it makes you not anchor and just kind of think about like both of those hold both of those spaces going forward. All right, back to you, Ethan.
So on her past medical history, she had asthma, hypertension, intestinal stromal tumor post status post the partial gastrectomy 2 months ago, and a L4, L5 spondylolisthesis. On her medications, she was taking amlodipine for hypertension, silamyrins for liver protection as a supplement, and astaxanthin. And she had a unremarkable family history and social history. Onto her physical exam, she was ill-looking, and on her head and neck exam, she had a icteric sclera with no lymphadenopathy. On her chest exam, she has bilateral clear breathing sound and no wheezing or quackles. On her heart exam, she has regular heartbeat and no murmur. On her abdominal exam, she had mild hepatosplenomegaly and a soft and non-tender abdomen. Bowel sound was normal active, and there are no signs of cirrhosis. On her general skin exam, she has no wound, rash, or petechia, and she has a overall yellowish skin. On her neural exam, she was alert and oriented ×3 and no cranial nerve sensory or motor deficits. And I'll also give you the initial labs. Her white blood cell count was 3.3. I don't have the full differential count here, but there are notable findings of 4.3% of myelocytes and 1.1% of metamyelocytes. Hemoglobin level was 10.9 with a notable 11% of nucleated RBC. MCV was 82.3. RDW was 20. Platelet count was 214, but the platelet count dropped to 97 3 days later. And that's the end of second aliquot.
All right, I can kind of comment on the past history and then pass the mic to Jack for going through the labs and the exam. So, I think like kind of the background is the most important thing is still that just tumor that he's out of the surgery that they had. In terms of like a liver supplement, I don't know what that liver supplement is. So what I would do would be Googling it and figuring out what it contains. Because oftentimes like some substances that are toxic to the liver, and you want to make sure that, a toxin is not at play here. The other thing that, when people are coming in with like jaundice and I'm worried about liver, your no misdiagnosis. There are a couple of no misdiagnoses, right? Like the big one is like acute liver failure. Thankfully, like, on exam, this patient doesn't seem like they're altered. We'll see if they have any like coagulopathy abnormality. And the other thing is like you want to make sure you don't miss a cholangitis type picture. And we don't have the vital signs, but probably the patient is like afebrile. So that's also becomes a little bit of a lower possibility. But those are the two things that I always like keep in mind as I'm looking through evaluating someone who's coming in with like what I worry about a hepatobiliary disease. Jack, back to you.
Yeah, I think the two things that I'm trying to sort of reconcile right now, we sort of said, okay, there's some signal for the intra-abdominal disease process, but then if we just take sort of a blunt force approach to looking at the CBC here, it looks like there's some abnormalities or some fishy things happening in the bone marrow, right? We see basically what I'm interpreting as early precursors of white cells, early precursors of red cells, right? The nucleated RBCs is a sign of early red blood cell precursors coming out of the bone marrow. And then we see a destruction or I should say a decrease in the platelet count in parallel with some mild hepatosplenomegaly. One way that we can get mild hepatosplenomegaly like this is if there is something that's leading to portal hypertension via something that is causing the liver to get big and swollen. So one thing that can do that is going to be congestion. Another thing that is going to do that can be inflammation. And a third thing that can do that can be infiltration. And if we see hepatosplenomegaly plus bone marrow disease process, my brain starts to maybe explore the possibility of a disease that's impacting the reticuloendothelial system, right? The reticuloendothelial system consists of the liver, the spleen, the bone marrow, and also the lymph nodes. We don't have clear lymphadenopathy on exam, but a little bit of hepatosplenomegaly, especially if there's an infiltrative disease process or an inflammatory process of the liver, that can lead to the development of some jaundice, and it can also potentially shut down the bone marrow. The inflammation, we can break it down into infectious and non-infectious causes of inflammation. That could be from something like a viral hepatitis, or as Sharmin mentioned, a drug-induced or supplement-induced hepatotoxicity. And that initial injury to the liver can lead to some inflammation and some early fibrosis that could lead to some of the development of splenomegaly as well if we have portal hypertension coming along for the ride. So I think what this aliquot is doing for me is initially I was very much in is there possibly biliary obstruction, right? There was recent intra-abdominal surgery. Somebody mucked around with a scalpel near the biliary tree and around the stomach. and maybe we're seeing a postoperative complication there. I think that hypothesis is certainly still possible, and we'll be able to explore that by looking for the presence or absence of biliary ductal dilation on imaging that's yet to come. But this aliquot also really expands my thinking into thinking about the possibility of intrahepatic cholestasis. And when we see intrahepatic cholestasis plus a slightly enlarged liver, again, the three categories I think about are congestion, although we don't see other signs of heart failure, inflammation, which could be infectious or non-infectious, particularly drug-related, or infiltration. And for infiltration, we think about the sort of characteristic infiltrated diseases, whether that's lymphoma, amyloid, sarcoid, hemochromatosis sometimes gets thrown in there, but we don't really have signal for that. And if we think about of those diseases, which one is most likely going to hit the bone marrow and potentially the liver, I think the possibility of a lymphoproliferative disorder starts to ratchet up potentially higher and higher. But again, the imaging will help us get clarity and allow us to hopefully make progress in deciding, is this extrahepatic cholestasis or is it intrahepatic cholestasis? And then with the bone marrow involvement that we mentioned with these early precursors, which could be related to a process that's leading to bone marrow replacement, or I should say bone marrow replacement by either abnormal cells or fibrosis. I think for me, that would certainly cross my threshold to also explore hemolysis, which I had sort of poo-pooed at the beginning, but I think it's coming back in stage right now, given the bone marrow or given the CBC findings.
All right. So BUN was 21.5, creatinine was 1, sodium was 141, potassium was 3.6, AST was 133, ALT was 110, alkaline phosphatase was 567, GGT was 356, total bilirubin was 14.5, direct bilirubin was 8.2, albumin level was 3.53, and CRP was 36. And alpha fetoprotein was 2.7, and HBs antigen was negative. Anti-HBC IgM was negative as well. Anti-HCV was negative. Anti-HAV IgM was negative. CMV IgM was negative. EBV IgM was negative. LDH level was 1,030, and heptoglobin level was 20.9, and the normal range was 30 to 200. So this is decreased level. And we also got a peripheral blood smear, which showed 2+ of nucleated RBCs, and the normal number and morphology of white blood cells with some myelocytes and metamyelocytes. And there are also decreased number of platelet with normal morphologies. We also have a abdominal ultrasound which showed left intrahepatic duct dilatations. And we also ordered a abdominal CT which showed no biliary tract dilatations. And eventually they did a ERCP, and they put a stent in there for the progressive jaundice. And we also have an abdominal ultrasound which showed normal liver size and a 1 centimeter liver cyst at segment 3, and also showed borderline splenomegaly and left intrahepatic duct dilatations. And I have a short video for the abdominal CT here. Okay, so I share my screen. So maybe you guys want to interpret that first, and I'll give you the interpretation from the radiology department.
It looked like there was something in the spleen, a positive arrow sign there. I don't know if that was a mass, an infarct, or if you all were able to tell the difference between that. But I think it looked a little bit peripheral, maybe a little bit wedge shaped. So the possibility of a splenic infarct comes up, but at least something in the spleen there was the big thing that jumped out to me. Did you see anything else, Sharmin?
I agree. The gallbladder looked a bit big to me. And yeah, the cyst seemed like very peripheral, and I don't think it's like playing a role. That was the other two things. Ethan, can you play again, please? I think everyone wants
Yeah.
to play. Yeah.
Okay, so as you can see, there's a biliary stent here, and they do think there's the gallbladder was slightly enlarged, and there's some wall thickening and air in the gallbladders. And there's the most notable finding is the hypodense lesion in the peripheral region of the spleen, and they suspect that's a splenic infarct. Okay, and that's the end of this aliquot.
All right, can we go back to the board, please?
Is it me or is it you? All right, I'll go. Yeah, I mean, I think that this is very interesting. So I think the big things for me that are taking us or coming down on the list, we didn't see any biliary ductal dilation. So the possibility of extrahepatic cholestasis comes down. We have a laboratory signature that's suggestive of underlying hemolysis with the high LDH, the low haptoglobin, but only I would say like a mild to modest anemia here. And then we have the finding of the splenic infarct on exam. What I will say about sort of all of these things coming together is I would say for me, this is shifting the action for me away from the liver, right? The liver is probably along for the ride if it's involved at all, and really turning us actually back over to the bloodstream, and particularly to the, again, reticuloendothelial system. The splenic infarct is interesting. If we just sort of take a sort of two-pronged approach, splenic infarct problems can be due to supply problems or demand problems, in the same way that a myocardial infarction can be due to supply problems or demand problems. Supply problems are going to oftentimes relate to embolic phenomena to the spleen, like you can see with endocarditis. It may relate to vascular issues. So, for example, a splenic artery occlusion or a splenic artery dissection. And then sometimes individuals actually have problems with the plasma flowing through the vasculature, for example, if they have a hypercoagulable state. So supply problems in a splenic infarct is really coming back to the framework that Robbie teaches: pumps, pipes, or plasma. The pump being the heart, cardioembolic; pipes being an underlying vasculopathy, like a splenic artery dissection or a vasculitis, which we don't necessarily have evidence of on the imaging findings, or a problem with hypercoagulability. The demand side of things is really related to anything that ramps up the lymphoproliferative or the myeloproliferative system. So things like leukemias, myeloproliferative neoplasms, and lymphomas, because the spleen is so rich with immune cells and immune tissue, and those disease processes tend to lead to a ramping up of immune system or immune cell proliferation, you can get local infarcts in the spleen from the increased production of different cells. If I were to say where then how this might play into things for us, right? Perhaps the spleen is having to do extra work here in the form of extramedullary hematopoiesis to make up for whatever process seems like it could be happening in the bone marrow, leading to the churning out of early precursor cells. Again, sometimes that's replacement of the bone marrow by abnormal clonal proliferations of cells, like we see in leukemias. Sometimes it's related to lymphomatous cells infiltrating the bone marrow, although we don't have lymphadenopathy that we see. And sometimes there's an underlying myeloproliferative neoplasm, for example, myelofibrosis, where if you get fibrosis of the bone marrow, other sites in the body have to pick up the slack in terms of making marrow cells, and the spleen can sometimes be one of those sites here. So I think that sort of is how I'm ramping this together, or sort of framing this together. Again, moving over towards the reticuloendothelial system and some sort of lymphoproliferative or myeloproliferative process. But again, we have to be aware of the fact that the bone marrow seems to be maybe taking an impact here. And then hemolysis is also at play, whether that's going to be a perineoplastic phenomenon. Many of the lymphoproliferative disorders can have a coexisting hemolysis, like autoimmune hemolytic anemias, or sometimes we actually have intramedullary hemolysis from these processes that replace the bone marrow. And so that's also potentially a possibility here. What are your thoughts, Sharmin?
Oh yeah, I love that. I agree. I think, there is probably something going on that is more infiltrative in nature, involving the bone marrow, the spleen. And maybe the liver. I still like to have that in my eye, if that makes sense, on that hepatobiliary system. I think gallbladder looked big. I'm so the question is like, is it two processes going on, or is it the liver stuff is just a reaction, whether like infiltrative, or potentially there's going to be a complications of that. The stent was placed, but I think always like making sure your colleagues review the imaging with you as well, like having the GI folks take a look at it. Because I wonder if there's like a mixed picture going on here too. So I agree, and I'm still kind of worried about the hepatobiliary system, if that makes sense. All right, Ethan, back to you.
All right, so some additional labs. IgG level was 788, with the normal level being 700 to 1600. ANA was negative. Anti-mitochondrial antibody was negative. Anti-smooth muscle cell antibody was negative. Direct and indirect home test was negative. And a SPEP showed no monoclonal gammopathy. And after admission, the patient also started to develop intermittent fevers, and blood culture was obtained and was negative. An empiric antibiotic was given, and we first give her ceftriaxone and then was shift to piperacillin plus tazobactam. And an ERCP was done again, which showed again no obstruction, and so the stent was removed. And we pursued a liver biopsy next, and the next aliquot will reveal the final diagnosis.
All right. So, I'm not sure what the final diagnosis is, but we can advance, Jack. Uh, I think in terms of like the ANA and the other workup being negative, I think like mixed hemolysis is a little less likely. I do is still curious about the bone marrow, what's going on. So like I think a bone marrow biopsy, I think you guys went with the liver. That is also awesome. I think the IgG being a bit elevated, like IgG4 disease is something we often think about with infiltration as well. So potentially that is something to think in the back of our mind as well. With the fevers, again, I do worry about that hepatobiliary system, especially with like the air in the gallbladder wall, I believe it was, so to make sure that that's not actually infected. The blood cultures being negative is reassuring, but I think that's something that I would actually have our surgeons evaluate the patient for and keep him on intra-abdominal coverage. The other question is like whether the fevers as other sign of inflammation, and there's like an underlying malignancy. I feel like lymphomas is always challenging to catch, especially in the more infiltrative nature, or is there more like granulomatous type of infection that can cause inflammations as well. So I don't know actually which one of those will be the final answer. Jack, what do you think?
Yeah, I'm with you. I'm sort of honestly, I'm sort of gamifying it for myself and being like, which of the diseases that we're thinking about can be diagnosed on a liver biopsy? And I think, drug-induced or lymphocytic hepatitis, lymphoma. I don't think of myeloproliferative neoplasms and those other diseases coming from a liver biopsy. And so I would say maybe I'm querying the possibility of a lymphoma that could tie this together, the junk in the spleen, maybe a little bit of action in the liver, intrahepatic cholestasis, some underlying hemolysis. That feels plausible. And then the only other thing I was thinking of was like, well, gosh, are there any atypical or bizarre infections that could get into the biliary tree and also cause intravascular hemolysis? The ones that I think about doing that are going to be viral infections that can sometimes lead to liver involvement and autoimmune hemolysis. So, for example, EBV and the EBV-like viruses can do that. And then the other ones are really devastating pyogenic bacterial infections, right? So like Clostridial liver abscesses. There have been case reports of like labs always being hemolyzed in those cases. And this doesn't really have the signature of a very aggressive pyogenic infection. And so I think we may discover a viral phenomenon. But again, I don't think about that as being diagnosed on liver biopsy. Like sometimes you can see the right viral inclusions but I don't think about that coming from liver biopsy. It's usually just lymphocyte infiltration of the liver in those cases. And so maybe sort of if we play the game, I'll say lymphoma with a possibility of a smoldering EBV or EBV-like viral infection potentially being underneath. And I'm curious too about how the GIST is going to play into this here, like whether it was a part of the phenomenon or true and unrelated. A question that I forgot to ask you, Ethan, was whether it was suspected GIST or confirmed pathologically on GIST, because I think, again, lymphomas can involve the GI tract. They can be sort of atypical appearing masses, and that could also be something that is part of this here. It could have looked like a GIST on imaging, but always, I think that was like another outstanding question. So a long-winded way of saying I'm not sure, but I think those are the leading two for me at this point.
I love that. The only thing that I would add is like DILI, as you mentioned, because, common things being common, drug-induced liver injury, after you rule out a lot of things, it tends to be the diagnosis. So, Ethan, we're so excited to hear what happened.
Yeah, so a liver biopsy showed infiltrates of atypical cells diffusely positive for CD20 and CD10, favor diffuse large B-cell lymphoma. And a bone marrow biopsy was pursued, which showed 98% to 100% cellularity and diffuse sheets of median-sized blasts, which account for about 95% of all nucleated cells. And the blasts are diffusely positive for PAX5, TDT, CD10, and CD33. And the diagnosis of B-ALL was finalized. And a RT-PCR for bone marrow was then done, which was positive for P190 PCR-ABL fusion transcript, which was also known as the Philadelphia chromosome. And we also did a FDG PET for staging, which shows diffuse uptake in bone marrow and liver. So the final diagnosis is B-cell acute lymphoblastic leukemia with BCR-ABL1 rearrangement, also known as Philadelphia chromosome positive BLLL. So the patient was given dexamethasone first because of her severe jaundice and poor performance status was not safe for chemotherapy. And after confirmed Philadelphia chromosome positive BLLL, she was given imatinib, the tyrosine kinase inhibitor. Yeah.
Wow, that is amazing. So just to confirm, there was both diffuse large B-cell lymphoma in the liver and then B-type or B-cell acute lymphoblastic leukemia in the bone marrow?
No. The liver is also the BLL, consistent with.
Okay. That makes sense. Wow, what a wild case. Ethan, thank you for this. This is very educational and really a fun one to get to think through. So yeah, thank you so much for bringing this to us. I have to learn more about this disease. I have heard rumblings about it, but never seen a case of it before. So I'm excited to get to learn more.
Yeah, fascinating case to think through. Thank you so much for presenting. This was like so educational. Learned so much. Really appreciate you, Ethan, and the way you also presented and the aliquots. They were all fantastically divided. So thank you so much for being such an expert presenter as well. We'll pass the mic to Mariana for the teaching points.
Hello, everyone. Thank you, Ethan, for this amazing case. Thank you, Sharmin Jack, for the fascinating discussion as always. So I will do a quick review of what we discussed today. So we started with jaundice, and to think about jaundice, we have two primary pathways: hepatobiliary disease versus indirect hyperbilirubinemia. Especially considering hemolysis, and we have to think where the action is. And the patient also mentioned that loss of appetite, what make us lean toward hepatobiliary disease versus hemolysis. We also have to think if it's a new process or a complication of a prior process, because the patient had a past medical history of tumor. So it's important to think about metastatic disease, compressing hepatobiliary ducts, or complication of the procedure that she had. And she also mentioned that she was taking a liver supplement. So we have to worry what does it contain, because we have to rule out liver toxicity in this case. And something that was also mentioned that is very important is the misdiagnosis. So in this case, with a patient appearing with a new jaundice, we have to look for encephalopathy or thrombocytopenia in order to diagnose acute liver disease, because it's a very important diagnosis and we can't miss that. And then the patient had CBC findings, abnormalities in the blood marrow. So we started to think about something in the blood marrow, but the patient also had signs of portal hypertension. In this case, we have to think about inflammation that can be due to infectious or non-infectious causes, such as drugs and supplements. We also have to think about congestion versus infiltration. And infiltration, we think about lymphoma, amyloid, sarcoid, hemochromatosis. And so with the image, we could see if there is an intrahepatic or extrahepatic cholestasis, and that can give us a clue of the etiology of the portal hypertension. So we also discussed bone marrow abnormality associated with portal hypertension, and in this case, it's very, very important to think about infiltrative disease. And this patient had no biliary duct dilation and had an underlying hemolysis due to the we could realize that because of the high LDH. And the patient also had splenic infarction. In this case, we start to shift away from a liver problem and start to underscore a bone marrow process. This splenic infarction, we also discussed that, and in this scenario, you have to think about a supply problem versus a drainage problem. And if we think about supply problem, a good way to do that is to think about pumps, pipes, and plasma, being dissection versus vasculitis, the main important causes when you think about pipes, and hypercoagulability if we think about plasma. And in a drainage problem, we can have like increased cells, decreasing the drainage of the blood and causing a problem in the spleen. So we have to think about leukemia and myeloproliferative disease. And moving on, we had ANA and other workup negative, so we would be less likely to be an autoimmune problem, IgG positive, IgG4 positive. So we started to think about infiltration. But we at the end of the case, we were still considering infections, especially because the gallbladder wall had signs of air. So we still had to think about infections. It would be very important to rule out them. And our final diagnosis ended up being an infiltrative disease. Thank you very much.
Wow. How did you do that so fast and so well? How did you put that teaching point all together so well? That was fantastic, Mariana. Thank you so much. Ethan, you had like a bunch of also great teaching points that you put in a chat. Do you want to read them out loud for people who are going to watch this on YouTube later?
So I think a key diagnostic thing there in this case is the leukoerythroblastic reaction with the nucleated RBCs and the myelocytes and metamyelocytes. And that's actually the most common disease that could cause that are solid tumors and hematologic malignancies. So although in this case, the peripheral blood smear initially showed no blast and normal morphology, we should track the peripheral blood smears and also considering the bone marrow biopsy. Yeah. Although in this case, liver biopsy should be pursued first. And ALL is usually also usually happen in children, but in elderly, it also can present. And Philadelphia chromosome is a unfavorable chromosome type in ALL. So yeah, so probably some teaching points here.
Yeah, no, thank you so much. Such a rich case, such a rich teaching points from both of you. And yeah, devastating diagnosis for her. I'm glad she had you all to figure out what was wrong, and hopefully she's doing okay. Thank you all so much for joining us. We really appreciate it. We'll see you during our next VMR. And thank you so much, BJ, for subscribing. Bye, all.